I'm really delighted to introduce my colleague, Dr. Clara von Karnebeek, who's an assistant professor of pediatrics in the Division of Biochemical Genetics at BC Children's and University of British Columbia. Clara and I have been research collaborators for a few years in the area of metabolic epilepsies, and she is well versed in all things biochemical. Clara is a native of the Netherlands and obtained her MD and Ph.D. in Amsterdam. And then did her pediatric training in both The Hague and in Amsterdam, then came to Vancouver and trained in biochemical genetics, and has been on the faculty there now for like 4 or 5 years, approximately.
4 years. Yeah.
And she's going to be speaking to us today about treatable inborn errors of metabolism that are related to intellectual disability. So, Clara, welcome. Thank you for joining us.
Yeah, thank you very much, Sid, and of course the organizing committee for the Grand Rounds to introduce me here. It's a great pleasure. Of course, showing our beautiful Vancouver, which we do not see in this time of year because it's misty over there and a bit rainy, but this is why I came from the Netherlands, presenting to you today really on behalf of a very large group of colleagues in Vancouver and also in the US and in Europe. So I really want to acknowledge their contributions. My conflicts of interest are not so many. My disclosures are listed here, co-investigator and consultant for several companies who produce enzyme replacement therapy or other medications for inborn errors of metabolism. So the learning objectives today are really quite ambitious, and I'm hoping to take you a little bit through time and speak with you about these treatable intellectual disabilities to provide an overview of the disease types, the therapeutic strategies that we use, an algorithm that we developed in Vancouver and applied in a large group of patients with unexplained intellectual disability, and we evaluated the effectiveness. And I think exciting times are here, and certainly your Genome Institute is definitely paving the way, but also in Vancouver, we're applying new technologies as everyone around the world. And we have recently started a study applying integrated genomics and metabolomics. And I want to show you some of our results, some of the new diseases we uncovered. So I think for this audience, I don't need to speak too much about what is intellectual disability, except to say that the term that we should be using is intellectual developmental disorder, which of course encompasses both global developmental delay, which we use to describe children at the age below 5 years, where 2 or more developmental domains are affected, especially speech language. Then above or age 5 years onwards, we can measure the IQ, and officially still we use the criterion of an IQ of less than 70. But of course, when we see these kids in our clinic, we realize, and the adults as well, that intellectual disability is much more than just a low test score. It affects many areas of life. And it's quite frequent. So about 2% of the population worldwide is affected, and that translates into about 3 million newborns per year who will go on to develop this condition. Significant comorbidity. We of course sometimes see kids who just have intellectual disability, but more often than not, there are systemic symptoms, sensory deficits, and obviously epilepsy, and especially the behavioral psychiatric disturbances can be significantly burdensome for families. And those are exactly the symptoms that seem to improve when we apply some of our treatments, movement disorders, and the list is still not complete. Static versus degenerative. And I think one of my key messages will be today to not only think about inborn errors of metabolism when you see a child who's going downhill. We've diagnosed quite a few inborn errors in kids who just have intellectual disability and who continue to develop quite well. And the medical costs. In countries like the Netherlands and Scandinavia, large studies have been done. And those show that these costs exceed cardiovascular disease and cancer medical costs combined. And this is, of course, because it's a lifelong condition. Traditionally, it's considered an unchangeable fate. The etiology is what makes our job, I think, so difficult when we see these kids, because it's extremely heterogeneous. And again, I won't go into this too much, but we divide it into environmental factors, genetic, which is an expanding group, which we also have to think of our trinucleotide repeats, methylation defects, where I believe we're just beginning to uncover those, multiple genes playing a role. And of course, then there's a large group of multifactorial for optimists and unknown for realists. And so still, despite evolving insights, often 2/3 of patients we don't find a cause. But with exome and especially with genome sequencing, we're seeing that the majority of genetic monogenic conditions is due to de novo mutations. So why is a diagnosis important? Again, I think we all realize this, that it has many advantages. And I think one of them, what I often see in clinic, is just ending that diagnostic odyssey. I mean, these kids often do get the $1 million workup. And of course, more accurate genetic counseling, more information about the future, better management options, and in the best case scenarios, some targeted treatments. And what am I speaking about? Is a child like this who presented at the age of 2 years with infantile Parkinsonism, who was diagnosed by my colleague, Dr. Horvath, with a rare congenital neurotransmitter deficiency, GTPCH. And this child was treated with Sinemet and hydroxytryptophan. And as you can see here on the video, he really catches up in terms of development. Of course, this is mainly motor delay, but if these kids are untreated, they develop significant intellectual disability, and especially a lot of behavioral disturbances is what we are seeing. And so when we asked this family, can we use this video to show colleagues and the lay public what is treatable intellectual disability, the parents said, well, we'll have to ask our son. They did, and he was really surprised to see himself like this. And he said, wow, this is really cool. I'm going to post this on my Facebook. And he's received many, many likes. So he's completely with it and doing very well. So I think with that, I've brought across the point that yes, we should care about these very rare inborn errors of metabolism, because many are amenable to treatment. And the outcome is often not as optimal as we've seen here. Sometimes we're just able to slow down degeneration or stabilize disease, improve daily functioning, or prevent brain damage. Many of the treatments are actually accessible, affordable, and quite safe. So we have multiple strategies to treat, and that's what I really like about this field, is that it all makes sense, and we can do many different things which are relatively simple, like providing a cofactor or limiting the intake. And it can get a little bit more complicated when we think about transplanting the organ which is affected, or providing the enzyme, or gene therapy, stem cell transplants. There's a lot to do. So PKU, phenylketonuria, we all know, we dream about it as biochemical geneticists, and it is actually the first intellectual disability. And here on the picture, we see John F. Kennedy with the two sisters McGrath, and you can see the child on the right, who's on the sort of play horse there. She's affected with PKU and was born before newborn screening, and her sister in the nice little dress who's standing there was screened and picked up early and treated with the protein-restricted diets. Since then, we've come a long way. I think the number recently was at 647 inborn errors of metabolism, excluding mitochondrial diseases. Newborn screening programs have definitely been extended, but in spite of all this, intellectual disability is still a burden. We don't diagnose all these diseases at birth to treat them. And that is what motivated Dr. Sylvia Stockler, who's the head of the Division of Biochemical Diseases in Vancouver, and myself to go on a crusade through the literature for about 3 years. We try to figure out how many of these inborn errors of metabolism are there. If patients are affected, they will present with developmental delay and intellectual disability, and for which there is a causal therapy available. So something that really treats the pathophysiology at the cellular level. So long story short, in 2012, there were 81 such inborn errors of metabolism, and this number has increased to near 100 recently. So that's really good news. Many different treatments, I spoke about these already. And as you can imagine, all rare diseases. And the sad thing is, although sometimes these treatments are as effective as I showed you in that boy on the first video, the evidence for the effective treatment is really very poor. And this is due to small patient numbers. And I think times are changing with new trial methodologies, but I won't go into that too much, however interesting. So we said to our colleagues, you know what, we have 81 treatable inborn errors of metabolism, you better find them. And actually the ACMG gave, and that's the American College of Medical Genetics, gave us feedback when we proposed with John Muschler and some colleagues to develop a guideline. They said, no, you guys cannot do this to your colleagues, that you promote this sort of idea that there are treatable causes of intellectual disability, because, I mean, a clinician will never be able to be sure that the patient does not have one of these conditions. So anyway, we understood that, but we still thought, okay, let's make sense out of this systematic review and translate all this information into something which we as clinicians can use as a protocol, which we published in 2014, and I'm happy to distribute if you're interested, because this is a little bit difficult to take in. The most important structure of this protocol is that it is two-tiered. And what we do in Vancouver and increasingly at other sites is that in all children with unexplained intellectual disability, that we apply this first tier, which appears to be about 450 Canadian dollars. Screening tests in urine and blood. They're all listed here. They are quite well available at biochemical genetics labs. And it's a pretty complete package in the sense that 60% of the 90 treatable inborn errors of metabolism can be diagnosed just by applying the first tier. The second tier is based on signs and symptoms. And we just want to emphasize that, of course, this is not all we do or advise in patients with intellectual disability. Of course, the chromosome microarray, which can detect a pathogenic variant in about 15%, those kind of tests should also be done. But we're promoting, even though it's rare, look for the treatable. And so we developed this app, which is called the TIDE, or the Treatable ID app. It's in the App Store and online, which supports this algorithm. And so you can search with signs and symptoms. You can find out a little bit more about the diseases and their treatments. And so our next step was to say, okay, now we've designed this protocol, let's try to evaluate whether it works or whether we are able to diagnose some patients. We realized that even though we were able to enroll 500 patients over 2.5 years, that still for rare diseases, this is an insufficient number, but we did the best we could. So in 3 divisions, under this treatable intellectual disability endeavor, we called it TIDE BC, we started the study. And so all unexplained intellectual disability patients, the protocol was applied, but only a subset was enrolled into the study depending on whether parents were interested or not for data collection and DNA and urine storage. So 2/3 were males, as is to be expected, a mean age of about 5, and the degree of intellectual disability varied from mild in about half of patients to moderate and even profound in 16%. Extensive testing had been performed before the study in about 2/3 of patients, and that is, I don't know if that's similar here in Seattle, but I often feel in British Columbia, some patients we see over and over and over again, but there are many patients who never make it to our hospital. And so this was not a naive population. They had been screened and tested before. And all of them had had newborn screening in one form or another. So what type of patients were these that were seen in neurology, biochemical, and medical genetics? A quarter had unspecific intellectual disability, 15% the autism was a pronounced comorbid or morbid feature, and then there were another 15% where the dysmorphisms or the congenital anomalies were prominent. Epilepsy in 17%, and only about 5% had a somewhat degenerative course or plateauing of development. So we applied our TIDE protocol superimposed to the American Academy of Pediatrics guidelines. And what we were able to diagnose was a confirmed diagnosis, confirmed meaning at a molecular level. We are not able in 1/3 of patients. So often our government does not approve gene testing, for example, for Angelman syndrome or you name it, conditions where the government has decided this does not impact management. So we end up with quite a significant number, 21% of the 500 patients where we're very sure of the diagnosis, but we just don't have the ability to confirm it at a molecular level. And so half of the patients remained unknown. TIDE protocol was performed in all chromosome microarray in 4/5 of patients, and the exome sequencing in about 10%. 30% of patients underwent an MRI, and this is, I think, what reflects what we in BC were able to do in these years previous. So 50% a diagnosis, not a bad score. But what I'm interested in is how many treatable inborn errors did we find? So in 5% of patients, we found one of our, let's say, 90 diagnoses. And half of those diagnoses were identified by just applying that first tier screening. And so sometimes the diagnosis was actually quite unexpected. There was a significant number of treatable inborn errors in unspecific intellectual disability patients who didn't have a degenerative course or multi-organ involvement. So here is a list of these 27 inborn errors of metabolism, and I just divided them up into the first tier and the second tier diagnosis. A few things here are important. The inborn errors of creatine metabolism are comprise, let's say, the relatively largest section of these first tier diagnoses. And this is something to keep in mind. Often I'm asked, what if I don't, as a practitioner, have the funds to actually do all your tests as you guys wrote it down? Which test should I be doing? Of course, it depends on the patient, but in general, I would say look for an inborn error of creatine metabolism. And I'll get back to that because it's frequent and relatively treatable. In the second tier, congenital neurotransmitter abnormalities were definitely prominent. And so in our institute, we're certainly not afraid of the lumbar puncture. Yesterday, Dr. Diemans, whom I'm sure many of you know, said to me, we're actually quite CSF happy. And tomorrow during child neurology rounds, I would love to speak to you more about that and some of the secondary treatment targets that we find. Going back to this list, you see, for example, glutaric aciduria there. This is something that we screen for in British Columbia. But this poor child had been a negative or had been missed by newborn screening. And this happens with other conditions as well. Intermittent maple syrup urine disease is another example for that. So, that's why we say, even though the child has had newborn screening, keep it in mind that it may have been missed. And if there is a presentation like that boy had with dystonia, really look for it very carefully. In any case, we have done also some cost effectiveness studies and more prospective studies are underway. But when we looked at what the TIDE protocol had done for us versus how we had practiced during the period 2000-2010, we were able to see that we had diagnosed more treatable inborn errors of metabolism. Not exactly fair because some of these diseases were only discovered recently. But what I think is the most important, what we found is that we were able to reduce diagnostic costs. even by applying this protocol in everyone, and so that means $400, $500 in everyone, it was better than what we were doing before, sort of random stuff. Diagnostic delay also was reduced, and that's of course crucial because many of these inborn errors of metabolism have a time window where you can treat and actually make a difference. And if you're too late, then the treatment doesn't do too much. So I spoke, yeah.
And that's actually way underestimating the cost versus benefit, right?
Yes, I would agree.
So you want to turn around and be able to sell this to your government, that it's cost effective to do this kind of screening, including essentially exomes. And so the cost includes the cost that you save of the care of that patient for the next 20 or 30 years, which is a lot of money. You only need a couple of people where that makes a huge difference.
Yeah, that's a very good point. And so thank you, because you brought across the most important. And so you might wonder, why am I not showing any sort of dollar amounts on that? I mean, we finally found a health economist, very scarce in British Columbia, who's willing to model that. And but I mean, it makes complete sense. And that's why I think we were funded for this study in the first place, because people realized that, yeah, just one patient can make a huge difference. And I think also with our colleagues in the community who are not in academic hospital and, you know, who don't have really time to even think about these rare diseases, what we've also noticed when we have disseminated and worked with an organization called Child Health BC, we disseminated the protocol to the pediatricians so that they could apply it as well in their practice. We really noticed that, you know, it really worked such that there had to be one single pediatrician who made such a diagnosis and of course was super proud, rightfully so, and saw the difference in the child. She started telling the colleagues, and there's now truly some enthusiasm about these very strange rare diseases. So we're quite proud of that. We're able to, so we set this up in such a way that the pediatricians know how to look on our site, can download stickers that they can put on the lab requisitions. They know the criteria, they know when to refer the patient to us and not wait for results. And these all go to a central laboratory in BC, and that's our advantage. So if there's an abnormal result, we in our biochemical diseases divisions are alerted, and we can contact the physician and get the child in, because I don't think that every child with intellectual disability should or can be seen in an academic institution. I think it would be great if much more is disseminated and done outside of the academic, already very full tertiary care centers. In any case, this boy is a nice example, 4 years old, who just moved to BC from the States, and the parents had been around many centers in the US where I think 15 different physicians took a look at him. He has a very unspecific phenotype with some seizures, autism spectrum, and looking back, some low muscle mass. So the pediatrician with a huge needle performs this first-tier screening, and what came out was an abnormal urine creatine metabolite profile with an increased creatine to creatinine ratio, normal guanidino acetate, and what that fits creatine transporter deficiency. And when the child was referred to us and brain spectroscopy was done, a low creatine peak was seen. And so he had many brain MRI scans, but not the spectroscopy, so therefore it had been missed. The gene showed a novel frame shift mutation, and so the diagnosis had been confirmed. And when we go to the app, you can search per disease, and I found that for myself and the trainees, it's often very nice because these complicated metabolic pathways are just on your phone and you can say all kinds of intelligent things. If you can read it, I'm not sure from afar, this is not such a complicated pathway, the creatine metabolism pathway. 2 synthetic steps by Agat and Gumt. Those are the enzymes. But the problem here is actually transporting creatine into the brain. And so there's a lack of energy in the brain, and also the transport between the different, the astrocytes and the glia cells is impaired. So what's the therapy? Not all children are amenable to treatment, but about 1/3 show a good response to creatine, glycine, and arginine. Glycine and arginine are the precursors of creatine. Very low evidence level. We recently did a review, and we found that definitely there seemed to be an improvement in behavior and in seizure control. So in this case, 5 months of therapy, all on oral supplements, which are tedious but not expensive. The MR spectroscopy showed an increase in the brain creatine to choline ratio, where it was significant. And so the parents noted especially improved communication, more energy. We measured some increased muscle mass and motor skills. So that was looking pretty good. But I was especially impressed by the story about his ability to communicate and reciprocate. So he used to smash his head against the wall. The mother said he couldn't communicate. The other day he stood at the window singing that the sun was shining. He shows empathy to his sister now when she's upset. And this is really amazing to us. And when I saw him recently, he's really become quite strong. And so sometimes his sister longs for the time that he had a low muscle mass and was not sort of beating her up, but he's doing well. Formal testing showed minimal change, and that's something that we often see as well, that we are quite impressed with the change of parents, and there's also some placebo and wishful thinking, I'm sure of it. On the other hand, there is real change in their behavior, but when they're tested, and certainly IQs, they don't really change. And that's because I think we're not looking with the right tools, and we have a long way to go there, I think, with rare diseases. Here, the mother of this child tells a little bit more about her experience. And before she does, please keep in mind that this condition seems to be as common as Fragile X syndrome, which we all love testing for, and at least in BC, we always sort of tick it. And Fragile X treatments are definitely up and coming, but here's something you can already try to treat.
Engaged in everything, so it's changed him tremendously.
So she's a carrier, completely unaffected, showed quite skewed X inactivation, and her brother, who'd been in an institution in South Africa, was diagnosed at the age of 3 years. So now moving on to a terrain where the expert is actually sitting in the audience, Dr. Gosby, and this has been the focus of our collaboration, pyridoxine-dependent epilepsy. And I'm sure you've learned and know a lot about this condition, but I want to tell you a little bit about today's, the new treatments that we're trialing, which really target the developmental delay. So we know that these usually pyridoxine-dependent epilepsy presents with early onset seizures unresponsive to anti-seizure medications, but often showing a significant response to vitamin B6, pyridoxine. So it's been used as a diagnostic therapeuticum since the 1950s. But the outcomes on B6 therapy have not been so great. So about 3/4 of patients suffer intellectual developmental disorder. And the MRI scans of some patients show ongoing tissue loss and white matter lesions. Here's a patient from Amsterdam who, as you can see on the right, at the age of 1 year and 9 months, showed marked ventricular dilatation and has even gone on to develop quite significant white matter lesions. This is not the case in all patients. In any case, once the underlying genetic defect became apparent, we as biochemical geneticists became very interested, because this is actually a metabolic epilepsy due to an enzyme deficiency in the lysine degradation pathway. And so there's this, what we think is a nasty metabolite accumulating, the alpha amino adipic semialdehyde, or AASA. And the P6C, which you see there on the left, is actually the compound that inactivates the pyridoxal phosphate. And that is the, let's say, underlying reason that when you give enough pyridoxine to these patients to overcome this inactivation, you often see a nice response in terms of seizures. But we think this ASA is actually the compound that causes ongoing brain damage. And with the B6, you're not treating this ASA accumulation. So right there is a new target for treatment, just like in PKU, just like in glutaric aciduria. Why don't we limit the oral lysine intake and also supplement arginine because this can competitively inhibit the transport of lysine over the blood-brain barrier. So we recently published with the group of Johan van Hove in Colorado and our colleagues in Europe a very small open label study in 6 patients and we treated both with lysine restriction and arginine supplementation. 3 males, the age was definitely variable, 3 months to 8 years. They had different clinical presentations, so not at all homogeneous group, but worth a try. And what we saw in general is that the toxic metabolites, this ASA, decreased in all of the patients, with the yellow bar showing the pre-diet and pre-supplementation ASA levels. And then the pink bar in each patient shows just what happens on the lysine restriction. And then when we add arginine to keep the lysine out of the brain, theoretically, we see a further drop. But most importantly, improved seizure control, development, and behavior. This is a boy that I follow in British Columbia who was started on the diet at the age of 4 years, and mother tells her experience.
And so that's how we kind of got to the diagnosis. He was 1 when he was actually diagnosed with that. I was happy to know what it was. At the same time, the prognosis for it wasn't the greatest. We started the diet, and within a week, he was fully trained day and night. He was talking in sentences. He started walking better. And I mean, this wasn't a week. It was very dramatic. Like, we went back home after starting the diet, and we had a physiotherapist, occupational therapist, speech therapist, and they were all like, who is this kid? What? This is crazy. That's crazy. Yeah, just blown away. That's another thing about the diet. Like, he was not social, no eye contact. Like, he almost had autistic characteristics to him. And as soon as we started the diet, it was just like a social butterfly came out. Like, he started playing with other kids, making eye contact. Like, it's huge, the impact that your diet has on everything.
And she actually goes on to say, you know, the impact is also not so great because I don't have any sort of meal choices. I stand in the supermarket and I buy the same things over and over again because of this quite strict protein restriction. And so while a diet seems sort of cheap and easy, I think many of you will know that it's not. And that was a reason that we thought, why don't we try to develop a diet app for this condition and other inborn errors of amino acid metabolism using an international database, which has all the information about lysine, protein, you name it, what kind of content. And so we've just launched this, and we're having a good time with it. I mean, mostly adolescents with PKU are using it, but also, let's say, younger parents. And what they can do, they can enter the the foods that they can search on foods to see the content, they can make their own recipes, etc. And then they have this sort of pie chart which fills up during the day if they track their intake, and they know when they've reached the limit, and they can export their food log. So we hope that this might change a little bit. And moving on, of course, to the next exciting venture, which has certainly started or is based here in Seattle, is the thought that this condition could be included in newborn screening panels. And so with Dr. Han and Dr. Gospi have developed in their group a blood spot method for diagnosing this condition. So all we need is to decrease the cost of that analysis and do a little pilot study. It sounds easy, it's probably not. In the meantime, and that's something we're working on, we're establishing a PDE registry where we hope to enroll patients, many of whom are in Dr. Gospi's registry already. This would be the digital version, and also include patients from around the world, because there's obviously a lot more to learn and more evidence to be established about these different treatments. So now moving on to these new diagnostic technologies, which are actually not that new anymore. I think this PDE is a nice example of how knowing the gene and understanding the underlying genetic cause can inspire or give rise to new thoughts about treatments. So we went from TIDE to TIDEX, where we decided that we wanted to find the needle in the haystack, look for rare mutations in patients with intellectual disability plus unexplained metabolic phenotypes, which we defined as abnormalities of intermediary metabolism, so strange organic acids floating around, neurotransmitter profiles which we didn't understand, or the lysosomal storage disease phenotype. These kids had been extensively evaluated, so they were really cherry-picked. Our bioinformatics analysis of the team is really excellent. I won't go too much into it. I know, and again, in Seattle, you're very much engaged in this area, but there's a nice pipeline that we've developed to filter all the data. Many of the patients are seen at our complex diagnostic clinic, which I think is the most fun endeavor at the hospital. We set up a while ago where we come together with about 4 or 5 different specialists and see 5 children in the morning, and then discuss differential diagnosis at rounds, and sometimes we include them in this study. So our first discovery in TIDEX was actually in 2 siblings, a sister and a brother, who presented identically. And I have to tell you that Seattle really helped us out with the brother, because we had no space in our NICU, and we didn't really know what was going on in his older sister, and so we were a little bit afraid. But he was transferred here with hyperammonemic encephalopathy, so high ammonia, high lactates, and low glucose. We did treat the older sister with carglumic acid, which we often do if we think there's something proximal in the urea cycles not working properly, and the child had responded a bit. The 3rd child was on the way, and the father had given me a call to say, you know, I would like to know what this is before the child is born. So we were motivated. Exome sequencing on both affected SIBs, and the parents identified a homozygous mutation in a gene called CA5A, carbonic anhydrase 5A deficiency, a homozygous missense mutation, which thank goodness was not present in homozygosity, just a carrier in this younger child. So carbonic anhydrase 5A, and I want to still maintain your attention because this looks pretty biochemical and maybe not so attractive, but it's actually pretty cool. So this had been described already by Dr. Sly, who's well known, Bill Sly, for his work in lysosomal storage diseases, but he is a man of all seasons and areas, and he had studied this enzyme in detail, developed a mouse, and he had predicted exactly how the human patient would present, and this was it. So he had said, you know what, carbonic anhydrase 5A produces and makes sure that bicarbonate gets into the mitochondria and finds its way to 4 different enzymes. And it may be a bit difficult to read, but one of the enzymes, CPS1, is in the urea cycle and hence the high ammonia. The other is pyruvate carboxylase, and this condition also presents with high ammonia, high lactate, and low glucose. The other 2 enzymes are the ones causing propionic acidemia and 3-MCC deficiency. And when we looked back, we saw all those metabolites floating around. But to be honest, I mean, when kids are in great stress, we often see many of these things. And so it was easy looking back, but we didn't put the pieces together. Anyway, it was a great explanation for this family. And of course, then we had to go and look for other families because we wanted it published. And yeah, no journal was really believing us with one single patient. So we were able to find 2 other families with a very similar phenotype. And I think that really accentuates the need that we share data and have quite open collaborations. And in our further studies, I'm always very impressed by it. It's actually the families and their Facebook pages and what they are able to do and share and come up with that allows us to validate diagnosis and understand what's going on. So this particular condition is a very nice candidate for newborn screening, and it's treatable with carglumic acid, but which is quite expensive, and we're now able to obtain because the government funds it actually for this reason in kids with hyperammonemia in our NICU. Interestingly, these children, when they grow up or when they go through their sort of 3rd and 4th years, they stabilize. And so we think that carbonic anhydrase 5B, another enzyme for which no human disease has been described, takes over the role of CA5A. And we found this condition in about 10% of unexplained hyperammonemia patients followed in Zurich. So it's rare, but it's definitely not ultra rare, so something to keep in mind. Summarizing our study results between 2011 and 2014, we completed exome sequencing in 47 families and excluded 5, made a diagnosis in 90%, so that is significant, novel genes in 11, and novel phenotypes in 23. What I find interesting is that we identified 2 coexisting phenotypes or diseases, I should say, in 5 patients. And these were not of consanguineous parents, but despite that, part of their symptoms could be explained by one gene defect and the second set by another. So I think in many cases where we do think, oh, this is a novel phenotype, we've never seen this before, is actually a reason to go back to the exome and make sure that we're not missing something. We had quite a few patients with mitochondrial respiratory chain defects, and we found that those were actually secondary to completely other genetic conditions, which is interesting for me that there are so many secondary effects on the mitochondrial function. As I said, our yield was high due to the cherry picking, due to a good bioinformatics team, and certainly a very close collaboration and discussion between clinicians and bioinformaticians. We were able to show, and that is now under review, that, I mean, definitely exome sequencing early on can be very cost effective. As you see in this boy who had $40,000 worth of diagnostic testing, the exome now would constitute only about 8% of costs. The impact on management of a diagnosis achieved via exome sequencing was significant. And so in about 43%, our management really changed based on the diagnosis. One example was just given with CA5A, and I will give another example now, but there is a condition called GOT2 deficiency, which I would like to tell you about tomorrow morning, which can be treated with oral serine, but sometimes the management is more symptomatic, such as providing a neurotransmitter supplements, or rather rigorous stem cell transplants, or deciding on chemotherapy And obviously, avoidance of triggers and malignancy screening is super important. So
I didn't quite get all of that.
yeah, this one, huh? Yeah, this poster is at the entrance of our biochemical disease division, and so everyone, including myself, runs away. It outlines all these pathways and metabolites. And with this metabolomics that we're hearing about, we're hoping that all these metabolites can be measured all at once, and we sort of understand what's going on if a pathway is affected. Not one platform measures all, but this one comes pretty close. Next generation metabolic screening, developed in Nijmegen in the Netherlands, and also working together with Dr. Wishart in Edmonton. It makes use of a tandem mass spectrometry, which I will not go into too much, but 10,000 different features are sort of analyzed or generated. Many of these are not endogenous metabolites, but medication or what we eat or adduct formation. So they've done a proof of principle study where they were able to show that with this one test, they could diagnose 23 very disparate inborn errors of metabolism. So the purines and the pyrimidines, the amino acids, organic acids, it's all found there. So using this technology, we started a new study where we do apply the two technologies in parallel, omics to treat ID. A 3-year-old boy with a storage disease phenotype. You see here, he's maybe a little bit coarse. He was born to non-consanguineous parents, a severe epileptic encephalopathy, developmental arrest, hypotonia, a leukodystrophy, and a very dysmorphic brain, short stature, and osteopenia, short limbs, many problems. He had a complete workup, including looking for congenital disorders of glycosylation. All was negative. So in Nijmegen, they were running this new metabolomic technology, and they found this unusual metabolite called N-acetyl manosamine, and it was present in all of his body fluids. At the same time, we were analyzing the exome, and we actually found 2 candidate genes which could fit his phenotype. And when we put the exome and the metabolome data together, we found this one matching gene which plays an important role in the biosynthesis of a neuraminic acid. And then you can see that these technologies really can act in concert. So 2 damaging mutations. And it appeared that the NANS is a key enzyme in the synthesis of neuraminic acid. And neuraminic acid is important for many things, also known as sialic acid. I won't go into too many details, but it is essential for the addition into glycoproteins and glycolipids. And so proving causality for such conditions can be very tricky, and we have different approaches, of course, to validating, finding other patients using model organisms, but sometimes just doing simple biochemistry can help us a long way. And we did a bit of everything in these patients. So we were able to find 8 unrelated patients with a very similar phenotype. We did some experiments to show that the enzyme activity was reduced, that there was accumulation of this proximal metabolite. And then some of the zebrafish and Drosophila studies are still ongoing. But what I think the most important thing is that this seems to be a condition that could potentially be amenable to treatment. And here you see the morpholino knockdown studies of NANS-A. There's NANS-A and NANS-B in zebrafish. And without going into too much detail, these are Alcyon blue stains, which show that there is an abnormal skeletal morphogenesis. And the bars there show that on the right-hand side, the orange and the green is depicting actually an abnormal chondromorphogenesis, an abnormal skeletal development, which is then with this bar, with the sialic acid addition, you can see that normalizes, and you can also see that on the pictures on the right-hand side, figure B, where you can see the top row is wild type and the bottom row is the morpholino knockdown on the left. And then you can see that on the left bottom side that when the sialic acid is added, which is the bottom row, that the zebrafish actually begins to look a lot like what is normal. And so with some of these cases, we show that this integrated big data analysis can really help us, and obviously is turning our practice around from going from a targeted metabolic screen, like I showed you at the beginning, confirming via targeted gene analysis, now with first doing whole exome and maybe metabolic screening, to then confirmatory metabolite testing. What's nice about the NANS deficiency is that with that N-acetylneurominic acid, and we've actually also found a biomarker for this condition, because the transferins look normal, even though this is a ciliation defect. So we hope to build the bridge a little bit more between these different data sets. And so this is the family here. The parents are super proactive, and they made the headlines of our local paper. In Canada, and then I'm almost near the end, we published a position statement for application of genome-wide sequencing. And in Children's Hospital, we've started a 500 trio a clinic where these can be referred from all over the hospital in the province for exome sequencing. And we're looking at yield, bioinformatics, and a lot about the ethics.
I've seen you with him, told us to say our goodbyes, and that we probably had 10 minutes left with him. A 7-year-old, he survived the hub of life support, and after a couple of days he was removed, and we got to hold him. But it was another 4 months of mystery and wondering what was going on. To just really not know anything about why that's happening is terrifying. It's the unknown, and knowledge is power. Digging and searching for more information about Isaac has really gotten us quite far, and we're learning and discovering new things. Now we've learned about this RMD1 gene and about other cases.
Yeah, and so what I wanted to say about this mother of the child with mitochondrial disease who's already passed away is that, the diagnoses are obviously important even if there is no treatment. So what shall the future bring? Will there be one metabolic screen, not when we think about lipidomics, but maybe the other metabolites, one genetic test, the whole genome, hopefully more and earlier diagnosis, and especially, I think, more patient involvement and using model organisms to help us and generating more evidence. So I would say my take-home messages would be to look actively for the treatable inborn errors of metabolism, and that there's lots of room for collaboration. So I hope that these umbrellas will draw you to Vancouver, if it's only by the email. I'm very interested in any unexplained neurometabolic phenotypes. And I want to acknowledge a long list of people, but really want to highlight Dr. Tarayo, Dr. Wasserman for the bioinformatics, and Sylvia Stockler, and again, the many others, because it truly takes a village to do this kind of research. And of course, you for your attention. And I'm happy to take any questions. Thank you.
So, wonderful accomplishment, and I can sense that you're justifiably proud at being able to put something like this together. It does take a lot of organizational skill. That's something that you don't get any education about in medical school, is how to get together with huge numbers of people, because a single person is simply not going to be able to approach this kind of problem. As I was listening to you, I have two specific things I wanted to touch on. One is just a question. When you get a sample of blood and urine,
yes,
you test it as best you're able currently. Hopefully you bank that, because as new ideas come along, we want to go back and retest and reexamine. Is that something we can expect?
Yeah, so thank you for your remarks and kind words and a very good question. So absolutely, we do always ask for permission and consent to bank. But if the parents, and this will not surprise you, but if they don't consent or haven't been asked, then we can only store for a very short, maybe a month. And if we want to access that for research, it's very difficult, with the exception of the CSF samples. And there, those are all stored for a longer time, and we've been able to go back to some patients and run, interestingly, this neurolomics, which is the next big thing. I don't know a lot about it, but some interesting diagnoses have been made. Yeah.
And if I may, the other point I wanted to touch on was there's a bell-shaped curve of just about everything.
Yes.
Including human behavior and human intelligence, whatever that is. So under that bell-shaped curve, presumably there are normal people that fall a standard deviation, 2 standard deviations, even 3 standard deviations away from the mean. This would be disturbing to parents who had a child who was really not performing at that level. But there may not be at least a simple cause for this. And it struck me that this touches almost on something that used to be called eugenics. The notion that, genes fall in these large pools, and you must be talking about that. I mean, there could be genes that are multigenic, but offer something either as an advantage or a disadvantage.
Yeah, I fully agree that this is a very good point. And I mean, I'm convinced that there are many of the cases whom we are not able to make a diagnosis of a simple monogenic disease will turn out to be multigenic. But maybe what a colleague mentioned in Edmonton, a developmental pediatrician, I'm curious for your thoughts about, that when we look at this population, if you have a family where everyone is maybe functioning in that -2 standard deviations or from the mean, it may be less significant of a finding than a child who has parents who are high functioning, or at least there's a huge deviation or a difference between parents and child. And this may not be a very politically correct thing to say, but his take on it was, those are the kids where we're most likely to find a de novo mutation or recessive, while if you're looking at a more, let's say, homogeneous family in terms of functioning, that's where he was saying, well, that could be where we find these multifactorial or polygenic disadvantageous maybe genes, and in the opposite families who have many advantageous polymorphisms. I don't know. But,
I mean, that sounds totally practical to me, and something that you could introduce without much controversy. I can't help but imagine that the people that function at the level of undeniable brilliance have some metabolic, genetic, advantages, do you want to call them advantages or characteristics that cause them to be there? And might we, in the fullness of time, discover what those things are? It will foist onto society a whole lot of interesting new questions.
Yeah, no, I agree. There was a study when I was in Amsterdam which was focused on high functioning, and they were looking at polymorphisms, but it was stopped because it was deemed not ethical. But who knows in the future? Yeah. Yes. And maybe in the meantime, sorry, so you have.
Yeah, so with exome screening, fairly often you get results that are difficult to interpret.
Yes.
And so how does your organization deal with that? You have a committee? Is it done by the lab? Is it done by a group of medical genetics clinicians? How do you determine a benign polymorphism from a pathogenic mutation, from a carrier of something, from an unknown?
Very good question. So in this study, we discuss each case with usually there are multiple bioinformaticians, biochemical geneticists, and the referring physician, who may be a neurologist or whomever who knows the patient well. And then when we see the list of filtered genes, and those are filtered according to standard criteria for rarity and non-synonymous and you name it, then everyone looks at it ahead of time. And before we meet, we all do our work, and then the discussion, obviously, you know, if using the in silico prediction analysis, in exact, the healthy population databases, things like that. But what I often see is a very interesting discussion where it can, you know, go either way, where the bioinformatician says, you know, you cannot neglect this mutation because it's been described as pathogenic, and the clinician might say, but you know what, the phenotype does not fit. I think it fits with this gene, yeah, but the variants aren't that strong. And so what we usually try to do is obviously apply the ACMG criteria, and then for many of these cases, because, and that is a luxury, we really try to perform some kind of validation at the cellular level. And I think there we have the advantage of neurometabolic phenotypes, that we might actually be able to measure an enzyme or do something relatively simple versus what you have to do when you have a developmental brain defect. But of course, I mean, we do our best, and we're obviously not always, or not nearly always, right. We do reanalyze the data quite often, and we convert to whole genome data sequencing as well. And we've, you know, had less success than I had hoped for, but I mean, some diagnosis made to inadequate coverage in the exome, and there's also been now 2 diagnoses due to mutation of regulatory variants, so really quite far away from the gene in the intronic regions. And we've also had now for GLUT1 transporter deficiency phenotype, 2 variants in the intronic regions. So, but that's going beyond what you asked, but we try to make it as multidisciplinary as we can, and to rerun the data over time. But it does worry me that sometimes we say, oh, it's inexact, this control database, and so it cannot be pathogenic. And now we're finding more and more that that's not the holy grail either.
And do you do anything about the American Board of Medical Genetics a couple of years ago said there's a set of 40 or 50 genes that should always be looked at when you're doing exome screening, and if you find a mutation in it, you have to tell the patient. If in one of these little kids you found a breast cancer mutation, what do you do?
So yeah, good question regarding the incidental findings. Makes our ethics board very nervous, so we usually don't try to talk about it. No, but we have that when during the consenting process, the parents are giving the option yes, no, to hear about that, exactly that list of genes, which is ever changing, of course, for themselves. But we have a set list for the children where if we encounter those, because those are actionable, as they say, we will report them. So we don't leave it up to the parents to say yes or no. In this study, we only had, but it was still significant, 1 incidental finding of cystic fibrosis in a male patient, actually the index patient, and he turned out not to have the lung phenotype, but the azoospermia. And yeah, so that does, but we are in a larger study that's ongoing now in Vancouver. Indeed, they are sort of replicating the numbers of about 1% to find those variants, the incidentals in patients and families. Yeah, but that's a challenge for sure. Yeah, because parents often say, "Oh, thank you, so good. You didn't find anything bad," but you know, we weren't looking for anything bad in them. We were filtering it according to their child. So I think it also gives a lot of false reassurance when you say, no, we didn't encounter anything. But therefore, I'm not a genetic counselor. It's too difficult. Yes, go ahead.
Sort of related to genetics, you'll have fair variant, not fair variant. Do you look at the metabolomics as a way to validate your suspicions, or is there a whole world of variants?
Yeah, so good. Yeah, so that's an excellent question, and I should have highlighted that more. But It's already taking up way too much of your time. That is the whole idea between saying, you know, the metabolome indeed. So, and we have some examples, but few and far between, where the exome was negative and the metabolome really showed, I mean, this pathway is very disrupted. And so let's go back. And yes, I mean, these were all known inborn errors of metabolism. So that was really quite handy. And vice versa as well. And I think this NANS deficiency was a nice example of, we probably would have found it anyway, but it was just very easy to say, oh, it's this gene and not the other. And yeah, so it's going back. But the metabolomics is really, really still in its infancy if compared to genomics, because you're dealing with these 10,000 features. Many of them you don't know what they are, or the lab people have no idea, even though they know exactly the mass. So this is the unknown, and you're looking for patterns of elevation or decrease. And the biggest problem, I think, is the internal control, so collecting several samples for the same patient, which is really not very ethical and doesn't, you know, go well, because you need that based on what, again, what we eat and all kinds of things. We want to know, you know, which ones can we just leave out and which ones are persistent. And then the second problem is just controls in general, age matched. And I think, you know, things like epigenomics, of course, which must play a huge role. You know, we don't take that into account, or we're not looking at that yet. So I think it'll get there, probably, metabolomics, but it's a limited data set, and it's a bit messy because of all the environmental stuff going into it. Yeah, it does. But another thing is that till now, those metabolomics data have not been shared. Like, for example, that everyone, you know, puts their variants, and so that is something that the Nijmegen group is now really working on, in the hopes that some of these metabolites will be identified. Yeah, and it's not confident, or it's not identifiable, a metabolome, so that makes it much easier from the ethics point of view to plunk everything on there. Yeah.
Maybe we should look one final time at that screen behind.
Oh, yes,
slide.
okay. Okay. Yeah, very soundly.
So when we climb our mountains around here, don't we take a carbonic anhydrase inhibitor
Yes.
to prevent altitudes?
Yeah.
That's going to be okay, right? It's okay for our livers and our brains.
It's absolutely okay, exactly, because you have that CA5B that's really revving up, so don't worry about it. But that is contraindicated. And what's more interesting is that you can sulfonamides, and this work was done by Dr. Sly in his mouse model, can switch the metabolism from CA5A to CA5B and vice versa. So that potentially, I mean, I know it's a sort of very old-fashioned, nasty antibiotic, but that's something that we're thinking about, you know, pretend to
I wonder if
using.
the carriers of that mutation would be at risk for,
Yeah.
when they took diamox, they would have more trouble with it.
That's a great question. Yeah, so maybe.
There's a lot of different subtypes of carbonic anhydrase.
Yeah.
If I remember correctly, you know, acetazolamide attacks one of them, but not all of them. The other interesting point about carbonic anhydrase, at least it used to be in the brain, that it was very unevenly distributed in cell types, and primarily in oligodendrocytes for some very strange reason. So knowing that you have a gene abnormality leads you to the next question about pathophysiology, where that gene is located. Does it work equally in every cell in the brain? Probably not.
No, exactly. Yeah, and so you're right. I mean, this is expressed most strongly in CA5A in liver and kidney, but also a bit in other tissues. Yeah, but there's a lot we don't know, absolutely. But this is these are the two that really bring the bicarbonate into the mitochondria, and so those are affected by the diazoxide. Yeah, so let's see what happens to these parents who demanded a diagnosis for their third child. Maybe I should be giving some preventive counseling to them as well, because I haven't done that. Yeah, but yeah, very interesting.
Well,
Thank you.
Yeah.
Yeah, sure. Yeah. Many people are asleep or gone. Thank you again.